Hello, I'm Elaine Worrell. I'm the Director of Pediatric Epilepsy at Mayo Clinic, and welcome to our webinar on the treatment of pediatric epilepsy.
Good afternoon. I'm Nick Weegen. I'm the Pediatric Epilepsy Surgeon here at the Mayo Clinic. We're going to do a presentation here on the treatment of epilepsy, and we encourage you to ask questions. We will try to answer them the best we can, and if you could please just try to keep the questions general. We can't make a specific diagnosis in a format like this. I appreciate that very much.
All right, so the topic today is on pediatric epilepsy. And we'd like to start just with a brief discussion. Do all seizures need to be treated? And we'll talk a little bit about the difference between rescue treatment versus prophylactic treatment. Prophylactic treatment being the treatment like medication you would take every day. We'll talk, and we'll spend most of our time actually on addressing specific treatment options. Most commonly, we would start with medication, but what happens if medicine doesn't work? It's not the right answer for all children. And we'll talk a little bit about dietary treatments and surgical treatments. And then finally, we will address how long do we actually continue treatment for kids with epilepsy, because as we know, many children with epilepsy ultimately will outgrow their seizure. So how long do we actually need to continue that treatment? So first of all, do all seizures need to be treated? And the answer here is no. The most common seizure that we see in children are febrile seizures. These are convulsions that occur with fever, usually in children between the ages of 6 months and 5 years. And very rarely do we actually need to treat those types of seizures with daily medicines. Additionally, some children will have what we call unprovoked seizures, so not triggered by fever or anything else, but those happen very, very infrequently. And if they happen very infrequently, the children may actually not need daily treatment. For most children with seizure disorders, however, we do talk a little bit about the possibility of having a rescue medication available. And that is given at the time of a seizure, particularly with a prolonged seizure, to try and reduce the duration of that seizure and to diminish risk to the child from a prolonged seizure. And there's a number of different rescue medicines that are available. One of the most common is something that we call Diastat, and that's a medicine that's actually given rectally. We use it most commonly in young children, and it is generally quite effective at stopping the seizures. For older children, we like to use options that are given by different routes, and we often will look at oral medication. There's a number of different options there, clonazepam wafers, or there's a liquid called diazepam or lorazepam intensol that can be given into the cheek to stop the seizure. And then also we have an option of giving medication into the nose, and that we give a medication called midazolam for. So for many children who have seizure disorders, particularly children who have the risk of going on to have prolonged seizures or clusters of seizures, we will use rescue medications. The other thing that's important for children who have seizure disorders is knowing what is reasonable as far as restricting their activities. Obviously, we don't want to restrict activities excessively because we really want to encourage these children to develop normally, but there are some important things to address here. One of the most dangerous places for a child with uncontrolled seizures is around water, and the drowning risk can be quite significant. And so children who have epilepsy or who have had seizures should be well supervised for baths and for swimming. For an older teen who doesn't want the presence of one of their parents in the bathroom while they're in the bath, showers are very, very safe for them to do on their own. With regards to falls and burns, this is really only a significant risk in children who have intractable epilepsy, so that's epilepsy that is not controlled well with medications, or in children who have frequent falls as a result of their seizures. Many families wonder about do they need to restrict their child from bicycle riding, and my usual recommendation there is that kids can ride bikes, but they should keep off the major roads. They should wear a helmet like any other child. And the only kids that I restrict from bicycle riding are children who have very frequent absence seizures, usually just until those seizures are controlled. And then some children have specific triggers for their seizures, the most common being flashing lights that can trigger photosensitive epilepsy. And in those children, they just need to be aware of what their triggers are and avoid things such as strobe lights. So when we're deciding do seizures need to be treated, it's a teeter-totter kind of effect. We're trying to weigh what are the risks of seizures and what are the risks of treatment. So let's first of all talk about what the risk of seizures are. There's often a concern that seizures can cause injury to the child or seizures can cause brain damage. And in reality, that is actually very, very rare and typically occurs only with more prolonged seizures. Seizures are often very frightening, particularly for families to witness the first time, and many families are concerned that a child can die as a result of seizure. And while that is true, the risk of death from a seizure is very, very unlikely. There is a condition called sudden unexplained death in epilepsy. This is a condition whereby somebody, usually with poorly controlled seizures, is found having passed away in their sleep. The risk of that is very, very low. It's about, if we follow 4,000 children with epilepsy, it happens to about one of those children every year. So it's very, very uncommon and usually occurs in children with poorly controlled seizures or those who are not taking their medications regularly. With prolonged seizures, those can also very, very uncommonly lead to brain injury or death, but very, very rarely. There is a concern about learning problems with seizures, particularly poorly controlled seizures, very frequent seizures in very young children. There's some evidence that those can have a negative impact on the child's learning. And then for many children with epilepsy, there's a lot of social stigma associated with seizures. For adolescents, the concern if they're having poorly controlled seizures, that really gets in the way of them being able to develop normal independence. And then on the other side of the teeter-totter is the risk of medications. All medicines, unfortunately, have the potential for side effects. Most of the medications that we use for seizures can have more nuisance type of side effects. There are some medications with rare, potentially very serious side effects. Families also often wonder about, is there a dependence on medicine? And that is actually pretty uncommon in the seizure medicines that we used. And then seizure medicines vary quite significantly in the cost, with older medicines being less expensive, but newer medicines can be quite costly. So let's talk a little bit about the goals of anti-epileptic medication. And the main goal here is that we can stop the seizures without stopping the child. So we don't want the child to have any significant side effects from the seizure medicines. So anti-epileptic medications, or AEDs, do reduce the likelihood of having a seizure, but just for the duration that they're taken. A lot of people think that maybe they will make it more likely the child will outgrow their seizures, and that's not true. If the child is going to outgrow their seizures anyways, it doesn't really make it any more likely that they will do so if you treat them with medication. There's also a lot of concern that delaying treatment may make seizures more problematic. And that's particularly important if we have a child and we're not 100% sure on the diagnosis, we're not clear if this is epilepsy or something else. What I usually do is delay treatment because there's really no evidence that will affect long-term outcome in seizure disorders. So when do we consider starting a daily medicine for epilepsy? Usually if the child presents with 2 or more seizures, we will think about that, but it really depends on a number of different variables. So first of all, what is the severity of the seizures? What were the medical consequences to that seizure? Obviously, if a child is having very prolonged seizures or very severe seizures, we view that as more serious as some of the milder seizures. What is the disability caused by seizures? What are the social consequences? So for example, an adolescent who is really hoping to get a driver's license, if they're having 1 or 2 seizures a year, that's going to stop them from driving, even if those are relatively mild seizures. So in that situation, we may be more inclined to treat. What is the period of time between those 2 seizures? Obviously, if the seizures happened 2 weeks apart or a month apart, we're going to be more likely to suggest treatment than if the seizures occurred 5 years apart. The timing of seizures that occur during the day when the child is active and about, we worry about that, and we would be more likely to treat that than seizures that occur solely at night in the safety of the child's bed. And then there are other specific factors that can increase or decrease the risk of recurrence. So we can look at specific seizure types. looking at different causes for seizures, and we can make a pretty good judgment as to whether that child has a higher risk or a lower risk of recurrence. And then finally, input from the child and family is really important. So if this is a seizure that really scares the child and scares the family, we would be more likely to treat. So once we make the decision to treat, what factors do we consider in picking the right medication? One of the main factors that we look at is what type of seizure does the child have, and what is the evidence that the medicine that we are going to use will actually help that type of seizure. That's important in epilepsy because we know that there are certain medicines that can be very, very helpful for certain types of seizures. Things like trileptal or tegretol can be very, very helpful for certain types of seizures, but in other seizures, such as absence seizures, it can make those worse. And then we look at the risk of possible side effects, and here we look at both factors pertinent to the child as well as the medicine. With regards to the child, we know that there are certain side effects that are more likely to be seen at specific ages. For example, children treated with Depakote that are very, very young have a higher risk of liver injury. Other medical conditions or other medications the child is on that may interact with some of our seizure medicines. And then does the child have underlying learning or behavior concerns? Again, some of our medicines cause greater problems in that regard than others. And then we look at medicine factors. So we know that there is a range of different side effects for the various medicines, and ideally we would choose one with the lowest possible risk of side effects. The other important consideration when we're picking a medicine for a child is the need for blood monitoring. If we can choose a medicine that does not require very frequent blood monitoring, I think everybody is happier about that, including the parents. We also look at the formulation of medicine. Is this a medicine that's available as a liquid? Is it a medicine that's available as a tablet the child can chew? Or is this a medicine that they really have to swallow? Obviously, the swallow medicines are very, very difficult to give in young children. We also look at the frequency of the dosing. Ideally, we would like to give a medicine just twice a day in the morning and at night, as most parents have no difficulty being able to do that. If we're giving medicines 3 to 4 times a day, oftentimes we need to rely on a daycare or a school provider to administer a dose of medicine, and that just gets a whole lot more tricky. And then finally, the cost and insurance coverage is important. Some of these medications can be extremely costly, and obviously we would choose one that hopefully would be covered by insurance. So when we're using medicine, we're really aiming for the lowest possible effective dose. And what we will do then is if seizures continue, we would increase the dose gradually as long as that was tolerated. In most medicines, or in most cases, a medicine reaches a stable level in the body within a week of increasing the dose. Many people often wonder, how long do I need to keep my child on this dose of medicine before I know if it's working or not? And generally we say if the seizures occur after a week of increasing that dose, that means that dose of medicine is not going to work. And when do we say that a medicine is ineffective for seizures? Well, we use that term if seizures persist at maximum dose, or if the medicine needs to be stopped at lower doses because the child develops dose-dependent side effects. When we look at how successful medicines are, overall in the kids that we see, about 60 to 70% of those children will respond very nicely to their first medicine, and the first medicine will provide good seizure control. If the first medicine doesn't work, the second is effective in somewhere between 40 and 50% of cases. But if the second medicine also doesn't work, we know the chance of success declines quite significantly the more medicines that have failed to control seizures. And after 3 failed medicines, seizure control is achieved in less than 10% of children in the long term. So usually at that point in time, because we are concerned that we don't want to keep giving the child futile medications with side effects, we usually then will look at other treatment options. So what happens if medicines don't work? And again, we define intractable epilepsy or medically intractable epilepsy as failure of trials of 2 to 3 medicines to obtain seizure control. So this means a child that has been tried on a couple of medicines, we've been able to use those medicines at good doses, and those medicines have failed the child. So then we look at options. So as we talked about, we could always go with more medicines. There's numerous medicines available, but we try and avoid that just because the success rate is pretty low. There are dietary treatments, and then there's surgical treatments we can look at. So dietary treatments are predominantly the ketogenic diet. This is a very high-fat, low-carbohydrate diet. It needs to be carefully followed by a dietitian who has a lot of experience in the diet, so it's carefully calculated and supervised. And it seems to be most helpful for children with very early onset seizures, often very severe epilepsy types. And some of these epilepsy types would include West syndrome, myoclonic atonic epilepsy, Dravet syndrome, or Lennox-Gastaut syndrome. And how well does it work? About half of children will have a significant reduction in seizures, and about 15% of children will become seizure-free on the diet.
I'm going to talk a little bit about epilepsy surgery. And again, just as Dr. Worrell described, we're talking about using epilepsy surgery in patients that have seizures that are refractory to medication. And the mainstay of epilepsy surgery is resective surgery, where we actually remove a portion of the brain from which the seizures arise. We need to document in these patients the seizures, first of all, are medically intractable and disabling. And we also need to find out where they arise and that they arise from the region to be resected. And we also want to make sure that that area can be resected without causing a significant disability to the child after the surgery. So they go through an extensive evaluation. It's a very careful evaluation to see if this is an option. And it usually includes a combination of multiple diagnostic studies, one of which is the MRI scan, a video EEG study in the hospital to record the typical seizures, a neuropsychological evaluation, and possibly the need for other tests such as SysCom and PET. SysCom is a type of study that looks at the blood flow in the brain during the seizure and between seizures, and PET's a procedure that looks at the metabolism of the brain. Surgery success depends on the type of surgery and whether or not there's an abnormality on the MRI and whether the area of the abnormality can be removed safely. Overall, there's about a 50 to 70% chance that the seizures will go away after the surgery. Some, but not all children are able to wean off their seizure medications following the operation. However, medications are usually not weaned unless the child and until the child has gone 1 year without seizures. Other surgical options that are not resective, meaning we don't remove the area of the brain, but are palliative in the sense that they have an opportunity and a chance of decreasing the frequency and severity of seizures, are other surgical procedures like the vagal nerve stimulator. This is an operation where we place an electrode on the vagus nerve in the neck that's connected to a wire that's tunneled underneath the skin to a second incision where a battery is placed that stimulates the vagus nerve. This procedure aims to reduce seizure frequency, and it also can be activated at the onset of a seizure to help stop the seizure. A corpus callosotomy is an operation where we divide the two hemispheres. The most useful type of seizures that are the most useful procedure for treating drop attacks or seizures where the patient loses control of their posture and can fall. Other newer surgical treatments that are experimental include laser-induced thermal therapy, sometimes known as Visualase, where an MRI-guided procedure is done to place a fiber optic probe into a lesion in the brain that might be causing the seizures. And then with precise monitoring, the laser light is used to induce a thermal injury to that lesion, to burn it essentially, and to make it go away. And that can reduce the seizures. This is usually used now for patients that have mesial temporal sclerosis, some tumors, some hypothalamic hamartomas, and heterotopias. Another surgical procedure that is palliative are other stimulation procedures like deep brain stimulation. This has been most widely studied in adults, and usually it's performed in patients that have partial and secondary generalized seizures And there's really limited experience in children, but in adults, about 54% of patients had a greater than 50% reduction in their seizures at 2 years. Similarly, another type of stimulation procedure where the electrodes are actually placed on the surface of the brain has been shown to be effective in some patients with seizures. In this particular device, the device can measure the EEG and then detect that they're having a seizure and then provide stimulation through the electrodes to help control the seizure. And the best study done, there is approximately a 53% reduction in their seizures at 2 years using this device compared to controls. And another less commonly used but also experimental procedure is something called subthreshold stimulation, where if we find that the area where the seizures are coming from is in the same area that controls language or motor cortex, we can stimulate at a very low frequency and lower amplitude to essentially block that area from the brain to cause the seizures. And this has been shown to be effective in a relatively limited number of patients.
So people often wonder how long, if your child is on medicine, how long should that medicine be continued? And overall, when we look at children who have seizures, about half of those children will ultimately outgrow their seizures. The success rate is about 70% if medications are stopped between 1 and 5 years seizure-free, but only about 50% if medicines are stopped after only 6 months seizure-free. So usually what we would do is that we continue on medication until somewhere between 1 and 2 years seizure-free. For many children who attempt to first of all come off medicine and that attempt fails, about half of them will become seizure-free again, and we can stop medicine a second time. Intractable epilepsy or poorly controlled seizures are very, very rare after withdrawing medications after a period of seizure freedom. So to summarize then, medicine is the first-line therapy for epilepsy, and it's usually started after the second unprovoked seizure. Between 70 and 80% of children are successfully treated with medicine, and side effects of medicine can usually be minimized. If 2 to 3 medicines fail to stop seizures, then we start to look at other options because we know the success with further medicine is quite low. Resective surgery can be a very effective option for children with medically intractable epilepsy, but it's really an option for selected children. There are many children who unfortunately are not going to be candidates for that. Minimally invasive procedures can help reduce the risk and discomfort and the expense of surgery. And then the ketogenic diet or other palliative surgical options can also be considered. So with that, we'd be happy to answer any questions. So one of the questions come up on how we can explain a diagnosis of epilepsy to a young child. I think that what we usually would, and obviously parents know their children best, many of our child life people or social workers can be very, very helpful with that as well. But we usually will talk to the children out there about there being some abnormal activity or a little a lightning storm or a little electrical storm in their brain that can just change how their brain is working for a short period of time. I think it's really important to reassure the child that generally those little electrical storms don't hurt them otherwise. For many children who are aware of what is going on with their seizures, and not every child loses awareness, it's important to provide a lot of reassurance to that child during the actual seizure. Second question is on absence seizures. This looks like behavioral issues on medicines, and are there other options to treat absence seizures besides medicine? Unfortunately, because absence seizures generally are considered a generalized seizure disorder, resective epilepsy surgery doesn't work for those. But one of the very good options if medicines don't work would be to consider a trial of the ketogenic diet. And there now are a number of different types of a ketogenic diet. There is a very strict form that was used classically, but we now have milder forms of the ketogenic diet. You still have to adhere to them very, very carefully, but they are certainly much easier to adhere to than the very strict form. Next question is, are seizures related to puberty? There are, when we look at epilepsy overall, it's not really a single diagnosis. There are multiple different types of conditions that can result in epilepsy. And there are certain types of epilepsy that are more commonly associated with coming on at certain ages. And specifically, there are certain types of epilepsies, for example, juvenile myoclonic epilepsy or juvenile absence epilepsy, that very typically occur around the age of puberty. So sometimes seizures can be related to puberty, but in many cases not. So then somebody has asked, what is the difference between focal and generalized seizures, and is one worse than the other? So focal seizures are seizures that really start in one particular area or one hemisphere of the brain. We think the generalized seizures really start sort of more diffusely in the brain. And is one worse than the other? I don't think we can say one is worse than the other. With focal seizures, if the seizures are starting from a single focus and they're not stopping with medicine, then we have the option potentially of looking at surgery to see if that can be helpful. And generally, resective surgery would not be an option in children whose seizures began all over at the same time. Okay, the next. The next question is whether once a medicine is started, the plan is to slowly increase to the optimal dose, and the child is doing well at a lower dose. Does it need to be increased? What we often will do is plan to increase to the lowest possible effective dose, and I think it's important to get most children kind of just into the lower end of the therapeutic range. However, there's no reason once they're at the lower end of the therapeutic range, if their seizures are well controlled and they're tolerating their medicine, we don't need to go any higher than that. We like to run them at the lowest possible dose. Okay, then a question has come on, can seizures last longer due to a high dose of a particular seizure medicine? That would be pretty uncommon. We know that in many cases, seizure medicines are suboptimal for control of about 30% of children with epilepsy, or seizure medications are suboptimal for about 30% of kids with epilepsy. But overall, it's pretty uncommon that medicines would make seizures worse. It can occur, but it is the exception rather than the rule. And then could an EEG diagnosis of generalized seizures actually be focal seizures? The EEG is a pretty good test, but not a perfect test. And some children, particularly with focal seizures that begin in the frontal lobe part of the brain, the EEG can sometimes trick us, and it can look more like a generalized seizure disorder. So that's why it's really important to not only look at the EEG, but to also get a very careful story from the family as to what they actually see at the time the child is having a seizure, because that information should be able to help us distinguish between a generalized seizure and a focal seizure. Okay, the next question, is it normal to have more seizures on the ketogenic diet? And again, the answer there is no. So the ketogenic diet doesn't work for every child. Overall, about half of children have a greater than 50% reduction in seizures. What we would normally do is continue that diet until the child has gone a month on that diet with good ketones. If their seizures are not improved at that point in time and the ketones are very good, it's unlikely that diet is going to be effective. And the next question is, a medicine that a child is allergic to the same as an ineffective medicine when considering intractable epilepsy? And here we do not look at those the same. In order to call a medicine ineffective, we do require that it be used in what would be a therapeutic dose to try and stop the seizures. If a medicine is stopped at a very, very low dose before it's had a chance to work, we can't call that medicine ineffective. Obviously, you have to stop it if there's an allergic reaction, but we would think of that as stopping because of a side effect as opposed to stopping because it was ineffective. Okay, so then a question about catamenial seizures. So catamenial seizures, that's a term that we use in women who have epilepsy, whose seizures tend to get worse around the time of their periods. And we know that hormonal changes can sometimes cause that to happen. The question is, are those seizures treated the same as other seizures? And will the child outgrow those types of seizures? That's a very good question. Are they treated the same? What we would generally do is maximize the seizure medicines the child is on. In some situations, however, if the child is really well controlled in between, what we will actually use is just a medicine at the time of the child is expected to get their periods. Normally we start the medicines up several days before the period starts, and then we would continue that for the first several days of the period, and then take that medicine away and just leave them on their regular medicine. So that is an option. As far as outgrowing those types of seizures, that's very, very difficult to say. Other things that can be very helpful for a catamenial pattern to seizures are to look at some hormonal therapies as well.
There's a question here about laser-induced thermal therapy and if it's an effective treatment for children with, I think, infantile spasms due to cortical dysplasia. And if so, what are the parameters in the size of the cortical dysplasia that would allow the child to be a candidate? Laser-induced thermal therapy has been used in patients with cortical dysplasias, but they have to be fairly small and focal so that the laser can be placed within them, and you can expect a lesion size to be made with the laser that can cover the whole lesion. And a lot of cortical dysplasias are larger than what you can see on the MRI scan. So there's some early evidence that it might be effective, but really it's too early to know for sure how effective LITT is in cortical dysplasia.
Okay, so questions come up, how do you start a ketogenic diet? When you're thinking about starting a ketogenic diet, it's really important that you don't do that on your own. It's a very carefully calculated diet. It needs to be supplemented appropriately, or the child can actually develop more side effects. And so in that situation, what I would suggest is that you speak to your child's neurologist about your interest in starting a ketogenic diet, and they could probably make some very good recommendations as to which center you could take your child to initiate that. It really does need to be followed really carefully by both a neurologist as well as a dietitian. The next question are seizures that start within 20 minutes of falling asleep. Is it coincidence or something in the sleep pattern? And again, that's a good question. We know that there are certain seizure types in children that can be brought on more commonly in sleep. The few that come to mind right away is there's a particular type of seizure that we see in children called benign epilepsy of childhood with central temporal spikes, or Rolandic epilepsy, and those characteristically occur shortly after the child falls asleep or shortly before they wake up. We know that they're sleep activated. We don't really understand the mechanism for that. And then there's other types of seizures that start generally in the frontal lobe of the brain, and those also very characteristically occur through the night, with many children having very, very active seizures at nighttime and much fewer seizures during wakefulness. So many times that's just not a coincidence. That's the pattern that we see with that particular seizure type.
This is a surgery question. For someone with intractable epilepsy, what are some of the typical things that would make them a good candidate for seizure? Well, the first thing that makes a person a good candidate for seizure are the seizures that are not controlled with medications, number one. And the second, and if we're speaking to resective surgery, is being able to localize where the seizures are actually coming from, and then whether or not that area overlaps with functional brain. So those are what makes the ideal candidate for surgery.
So the next question I think is a tough question, and that is, what is considered effective seizure control? No seizures, 2 to 3 a month, is seizure-free an obtainable goal? And for many children, we really aim to get seizure-free, and that's always our first goal, is to try and get a child completely seizure-free, because we think with that they will actually be able to learn better, they will have less potential behavioral concerns, they will be able to gain more independence. So for most children, we really would like to see seizure-free as a goal. However, our science and our treatments are still not perfect. We still need to work harder to get better treatments for, unfortunately, many children that we see. And so this is really a judgment or a judgment call, I think, that's very independent for every child. So we know that there are children who have very, very frequent seizures, 20 to 30 a day. And if we can get those children down to even having maybe 1 seizure a day or 1 seizure a week, that's a really, really big improvement in their life. And the teeter-totter that I showed you, we're always kind of balancing that teeter-totter. So we're balancing what are the effects of those seizures and what are the effects of the treatment. And sometimes in children who have seizures that are very, very difficult to control, we do look at that balance, and we really rely very much on the family to let us know as well. But for many of those children, we know that the seizures probably are less, if you're having a few seizures, that is less problematic than adding a bunch more medicines or a bunch more treatments that are unlikely to be terribly helpful. So sometimes we have to find a balance. But for most children, I think our goal should be seizure-free if that's obtainable. So the question is, I come up on a specific type of seizure disorder called benign myoclonic epilepsy. So this is actually a really rare seizure disorder that we see, and it occurs generally in the first year of life, and the children have what we call myoclonic jerks. There's a particular EEG pattern, and these children generally have normal development, enjoy normal development. And characteristically, it can be a tough diagnosis to make accurately, but if this is what it really is, the long-term prognosis is very good. The children generally respond really well to medicines, and children outgrow this form of seizure.
Thank you for joining our webinar, and please feel free to leave questions for later. Thank you very much.